panel button, the chat function, and a submenu button where you will also find the Q&A and polling panel buttons. Attendee microphones have been disabled for this meeting. In order to verbally ask a question or give a comment, you will need to raise your hand. The button to do this is in the lower right corner of the participant panel. The host will acknowledge you and unmute your microphone for you. Once you have several panels open, things may start to get cramped. Use the caret button to the left of the panel name to expand and contract panels without closing them. Within the chat panel, you have the option to select a recipient. Do this in the drop-down menu. Once a poll is opened, the panel should appear automatically. Select your answers and hit Submit when finished. You may change the layout of your windows by selecting a different view in the upper right corner of the video screen. Here is an example of your 3 options. If you experience any technical issues, please message the host and we will assist you as quickly as possible.
All right, I think we're good. So welcome everybody, and thank you for taking the time to virtually attend our radiation committee meeting. I hope that you're all able to attend.
And 9 times out of 10 it's VPN issues. Yeah, we had the same issue with KPMG yesterday.
So hopefully you're all able to attend some of the other SWOG sessions. You know, one thing I wanted to say here as we go through is the lack of an in-person meeting really makes some of the casual, informal conversations that we would like to have after a little bit more difficult. And it's kind of a shame. It's one of my favorite parts. But if anyone needs help with anything or advice with anything, I want you to please know that you should reach out to me. We have an ambitious agenda today. We have quite a few speakers. We have Dr. Kachnik is going to present a little executive summary. We have some study presentations, and then we've asked each of our disease team liaisons to give a brief summary of the active and pending trials, kind of going through their committees. To get things to end on time, and I don't know about you, but I really need things to end on time today. We're all going to need to be pretty brief. So our speakers really have like 3 to 5 minutes. So I would ask you to concentrate on the schema. That's always the money slide. You know, for open studies, we really want to concentrate on making sure that everybody has them open, and if we've identified any barriers to enrolling. For the pending studies, it's a great time to get some feedback, some input, and gauge the level of support you're going to get. I will do my best to keep an eye on the chat and the QA functions, but I am historically really bad at that. So we're going to just, you know, go through this as we go. So with that, I'm going to turn the agenda over to Lisa for her executive summary.
Roy, next slide, please.
Do I have the slides? Oh my God.
You're doing well. Good morning, everyone. So I wanted to just give a brief executive officer update, trying to show you where we fit in on the SWOG organizational chart, but also more importantly, what are some of the advantages to being in the Radiation Oncology Committee and some of the upcoming grant opportunities through the Hope Foundation. So this is the SWOG org chart, and you can see up top is the Board of Governors, which we all vote for and have term limits. And Dr. Blanky is the group chair to the far left. And underneath that, we have, to the right of the group chair, we have senior advisors, executive advisory committee, executive officers, which I'm one of, mostly for the non-medical oncology support committees. And all of our committees, both the actual disease site and the research support like us, are under the advisory committee and the EOs. And just to give you a little bit of more information about how SWOG is organized, just for some history, all the cooperative groups, each one of the 4 adult groups has the CTEP side of the house, which is a separate grant, and that's really for the disease site committee protocols. And then in the orange on the right side here of the org chart is the NCORE, and that's the NCI-sponsored community research organizations. And that's a grant, and our institutions have to apply for them. There's about 40 of them, and about 20 of them are minority-based. And if you look at who accrues to trials, it's always the community folks that have more accrual than all of our academic centers. So they're really important to us. And the NCORE side of the house is a separate NCI grant, but we can participate with concept opportunities, secondary analyses on both sides of the house. Next slide. So these are the actual disease sites on the left, and many of you are important liaisons to them, and we'll hear your reports towards the end of these 2 hours. And on the right are the NCORE committees. And again, all of this is opportunities for us. Next slide. These are the research support committees, which we are one of. Next slide. And this is what I wanted to focus on. What are some of the opportunities for all of us on the call? Well, you could be a co-chair on a trial, especially for a secondary endpoint on radiation. You can help with radiation QA on a trial. We can submit new concepts from ourselves as PIs to all of the disease sites and that NCORE side of the house. Secondary analyses, we have a couple underway. Finally, we talk about them with our Rhode Island Quark representatives all the time, like which of our trials have rich radiation imaging and DVH information. So we finally went back and applied and got permission to do a secondary analysis on remember the cholangio trial? So that's just one opportunity that we made happen. There's travel grants for our new or junior members, so always think about that, and that's on the HOPE site. And then HOPE Foundation grants, and I'm going to go into that a little deeper. Next slide. Oh, so I show the secondary analysis. Good, I forgot. So this is really a research committee or support committee collaborative effort, because it was the surgery committee, some key members, and some of our own RAD-ONC members who worked together to do this. And Dr. Horowitz, who's our new GI liaison, is leading one of the efforts, because we're actually hoping to get 2 papers out of this. Next slide. So we know the trial was a simple phase 2, looking at both patients that had R0 and R1, and they had radiation, different doses for each. Next slide. But the questions we were asking were twofold. One, that the surgical committee wanted to ask about how did folks do when they were lymph node positive, because there's not any good prospective data patient population on that. And then how did folks do depending on what they got for radiation and their doses? Because again, you know, this is sort of a more rare tumor for us, so there's not anything prospective on this. So again, a rich secondary analysis that we can do for any data set, and here's one that is going to produce 2 papers, and maybe give us something hypothesis driven to add to one of our next developing studies, because the GI group does continue trials in this area for localized disease. Next slide. So I'm going to finish with the HOPE Foundation, which is our foundation arm of SWOG. and they are so gracious in fundraising to have lots of money available for us to support a lot of the things we don't have support for on trials, as well as data from submissions asking for potential Hope grant support to do important preliminary data, whether it's lab or pilot, to get hypotheses that can inform future trials. So here are just some of the research supports. One is the SWOG Hope Foundation Award, and this is actually $250,000. So it's a big award from the Hope Foundation, and it's really trying to get the data to inform another trial, but it could be translational or clinical. I mentioned secondary analyses support. We didn't have to apply for that because it wasn't resource intensive for the stats for the cholangio trial, but other secondary analyses might. So there is an opportunity for that. One that's coming up is the Early Exploration and Development Seed Fund. And again, that's a smaller grant, but kind of like the impact. It's for preliminary research that could lead to a SWOG trial. And then there's educational funds and trial support for sort of correlative studies, whether they're patient-reported or more so laboratory studies, where we just didn't have the funding on that initial trial to the NCI that gets run to do these things. So it's often that we apply for BISQUICs and other things when we send our NCI trial in to, get reviewed and hopefully approved. But we don't get those BISQUICs, and the NCI doesn't always have money to support the rich imaging, the correlative biology, and the patient-reported outcomes. So the investigator, who's the PI or the co-PI with an endpoint, has to find additional funding, and here's a mechanism. Next slide. And then there's career development opportunities. We can post these slides and pass them around, but one that's been really great, and we've had folks from RadOnc receive this, is the Dr. Coltman Fellowship Program. And this is 50 grand for 2 years of salary support to make sure we have protected time, again, to pursue research initiatives that will inform maybe secondary endpoints or potentially even the primary endpoint of another trial. But there's grant writing workshops, there's the Young Investigator Training course, which you've heard me talk about a lot. And anytime we have a new concept, especially one that's endorsed already by the disease sites, we should also have our PIs go apply for the Young Investigator Training course. There's career engagement awards, and one that's coming up is the John Crowley PhD Award. And that's a 1-month residency, giving a unique opportunity with the stats folks over in the West Coast. Next slide. And then there's some community support, and this is where the travel funding comes in as well. And the Hope Foundation gives us money when we invite speakers, when we have live meetings, hopefully someday soon again. I'm going to hope for like 2023. And I think that's all, but maybe Roy, go to the next slide. Yeah. So does anyone have questions on anything? I can't see, I don't know, because if I'm in the panelist area, whether I can see everyone's chat, but I can, I think. So I don't see any questions, but feel free to also ask questions by chat and I can help moderate that. Great, thank you.
Thanks a lot, Lisa. So we've got a number of kind of study presentations. I think we got the right, so this is the one we want to skip. So
this is the one we're going to talk about, and the SRS one, unfortunately, we'll have to.
Oh no, this is the right one. I'm sorry, this one. Yeah. So so Dr. Amini, I'll hand it over to you.
Thank you, and I'll try to be quick. This is just a concept idea, whether it's appropriate for SWOG or another type of combination multi-institutional study. But we're working on designing the study here of a phase 2 randomized trial of using SBRT for oligoprogression, non-small cell lung cancer. You can go to the next slide. We can skip through the background. I think most people know. I would say the main takeaway with this is that there's so many. The terminology gets a little confusing, especially when I'm talking to some of our other colleagues not in radiation oncology. So just to kind of clarify, these are patients where they've been on, say, a year of first-line therapy and now are having 1 to 5 sites of progression. And our practice, and it hasn't been on protocol, kind of just open up a protocol just to collect them here, would be if you have a few areas that are progressing, instead of switching to second-line systemic therapy, we treat those with SBRT to really maximize their duration of first-line therapy. So that's sort of where the thought process came. And I know a number of places are doing studies like this or considering it. I'll go to the next slide. So our hypothesis was that the addition of SBRT in the oligoprogression progressive setting, which we define as 1 to 5 sites, will lead to an improvement in progression-free survival. We can go to the next slide. These are just some of our objectives. So primary objective would be progression-free survival. We look at overall survival, duration of systemic therapy at time of enrollment. So really where a lot of the meat of this would be is that radiations, the hope is that it's really prolonging that first-line therapy that the patient's on. Also evaluate biomarkers to evaluate immune response to SBRT. I'll predict for better patient selection on who are the patients that are really oligoprogressive, looking at local control, and of course the toxicity profile and quality of life of these patients. Go to the next slide. And some exploratory objectives that here it's mostly been about funding to try and do some of these, but if we were able to get some funding to really go in there and look at if we can develop biomarkers to predict responses to these patients, create a gene signature panel that can assess response to radiation. These are in patients that are, at least it was the population I'll get to, are really the patients that are getting immunotherapy. So we look at whether PD-L1 predict for treatment outcomes. Go to the next slide. I think I'll jump, but this is just the therapy. So these are, I'll get to the study schema, but these are non-small cell lung cancer patients, EGFR ALK negative, that are getting immunotherapy plus or minus chemo, and SBRT doses. I've just put this based on other studies, based on our practice, but that's always open to be modified. And then the standard of care arm, which would be considered the systemic therapy alone arm, would be next second line systemic therapy. So that would be at the discretion of the medical oncologist. And we can go to the next slide. So maybe I'll skip through this because I have it on the study schema, but we can go to the next slide. I think that's the study schema. So I'll kind of spend the remaining time here and really get people's feedback. Of course, there's a lot of talk on this subject, and I'm open to people's opinions. But again, looking at oligoprogressive disease, these patients these were considered the EGFR negative patients, ALK negative patients. So they're on immunotherapy, plus or minus chemo, 1 to 5 sites of disease. All are amenable to SBRT. The primary would be controlled, and they'd be randomized. The only stratification factor I really thought about, we could also consider SCC and adeno, but it would be 1 to 3 versus 4 to 5 sites of disease. And then they'd be randomized to SBRT to all active sites or progressing sites in continuation on that same systemic therapy they're on, or systemic therapy alone, which would be second line or third line based on the medical oncologist. And again, the primary endpoint that we designed preliminarily was progression-free survival. We've done some number calculations here, but if we do a superiority study with a progression-free survival, the patient numbers are actually pretty low, more around 100, 120, which is sort of potentially promising. So I can pause here. The next slide just goes into some of our stats calculations, but really want to spend some time here. But have to get this feedback. and I appreciate your time.
Can we just go back one slide so the schema is up there? So we talked about this at our lung committee monthly call, and you know, a lot of the comments could be boiled down to the fact that people thought this should be confined to a narrow disease with a specific drug, right? As an example, doing it in EGFR positive patients with osimertinib. I think that's the way it would fit into the lung portfolio. I'm personally not sure that's the best design for this trial. But I also told Arya that I don't really think I know what the best design for this trial is. So I'd love to hear some comments from people on a design that they would be interested in participating in.
While we wait for the comments, I'd just like to add that Arya was a young investigator, and he went to the course.
Oh, there you go.
Yeah, we developed, and Dr. Katchik was a huge supporter of it. That SRS protocol, unfortunately, was finally approved, and then because of conflicting studies, it's kind of on the back burner. So that's where that is.
That's the life of an investigator. So
Yes,
you're in those phases. That's right. Be patient.
Yeah.
So I do have a question. How many patients would you estimate for overall survival as a primary, although in your case, and as in the case of the other sets that have been reported in the literature, it's been progression-free survival?
Right. So I had our stats. This is all preliminary, and our statistician got mad at me at throwing this last minute to him, but he got around 250 at the lowest for overall survival, but realistically, I think it'd be around 300 at a minimum to patients for overall survival.
I think one of the problems that comes up, and the same with Aria's SRS trial, is there is this perception that because you write kind of a basket protocol that it competes with a bunch of things and therefore won't get approved, which I think has caused sometimes these designs get narrowed down for reasons that are not, I don't know, not really related to the primary endpoint so much. I know the chat function is probably not broken, and I find it hard to believe that this group doesn't have any comments. There's a little yes/no thing, even if people want to indicate their interest in participating in something like this, that might be helpful. Or Aria, if you have any kind of more specific questions you want to throw out for the group, maybe we can stimulate some feedback here.
Yeah, and I'm seeing a few, I just clicked on the Q&A. I think we get to looks like overall survival. We tried to answer it. It'd be at least 300 patients if that's the primary endpoint. And for oligo progression, can be any line of drug to qualify, and that's a good question. I think that was what we were kind of debating on. We thought it would be this patient population would be our EGFR ALK negative patients, or we be EGFR positive. But if they're the negative, it would be a checkpoint inhibitor like pembro plus or minus chemo at the discretion of the medical oncologist.
And I suppose there's really no reason we would have to limit it to non-small cell too.
Right. So when I started it, I mean, when we were thinking about it here, at least we thought head and neck, non-small cell, even RCC. There's other places I know that are doing, one institution that's doing RCC. I mean, I'm sure the other places are doing similar trials, maybe smaller trials. But I assume, I think one of the biggest criticisms of this arena has been there's been these big basket trials, which I personally like, but I know it makes it a little bit more heterogeneous.
Agree. I mean, I think your approach is pretty standard, based on what we've seen from the other published data sets that include many comers. So that I like. There is a question, some other area here on the chat.
Yeah.
There was some concern if, as a community provider, that maybe patients or the providers wouldn't be comfortable with the systemic therapy alone arm. I've been looking at trials that sometimes there isn't a systemic therapy alone arm, and that's when I get a little concerned, because I think that is sort of the standard of care right now. But maybe provide your thoughts on that, Ari?
Yeah, I would agree with you. I think, you know, along the lines of, I guess if there's one site, I think this came up on our call too. If there's, say, one site that's progressing, some people thought, well, should be SBRT, but there's really no data for it. We all do it. I would say that's similar to the NRG oligometastatic trial we have open now, that, where they seem to be enrolling fine. But it might be that people won't want to enroll if there's just one site progression and they'll just get SBRT. And I think that's fine, but I would say the standard is still the systemic therapy alone on it. Though I like that people like that SBRT is the way to go. That's great.
Roy, as a senior investigator on our thoracic committee here at SWOG, what would you think are the next steps for this?
We Ari did a great job of presenting it, and the question is, what David Gandara suggested really was narrowing it down using some kind of biomarker. But I think, ultimately we have to make a decision here. For a basket trial, I think it's, I think there are different questions than if you identify and want to do this in EGFR mutant. And so I think the first thing is to figure out which trial we want to do. I personally like this design. I'm not sure how much enthusiasm there was for it. So I think, Ari, are you presenting this on Friday at the lung meeting, or?
I'm not sure. I don't know if I can ask Karen Kelly, but I don't think I was going to. I'm happy to.
Well, maybe we'll take this one offline, and maybe Dr. Decker could reach out to those senior investigators and see if he can present. Because I think, you don't want to sit on this, because from my perspective, from the 4 adult groups, they're taking every homogeneous population now and giving a trial like this to try to suss it out. So I think it's important to come up with a design that our lung committee is happy with, and hopefully get support and push it forward.
Yeah, and I think what we talked about yesterday on the phone was trying to identify a population where there was nothing competing. And I think that would help the case, and hopefully we can find one that, so we'll keep working on this. Maybe, Ari, we can set up a little chat with Karen and talk about what's the right population to do this in.
Okay.
All right. In the interest of time, we're gonna move along. And if people have more comments, please feel free. So our next speaker should be Chad Rustov, and Chad was gonna try to get here at 11:30, and I don't know if he's made it on yet or not.
Yeah, I'm here, Roy.
Oh, great, Chad. I'll turn it over to you then.
Okay, great. Thank you so much for the opportunity. So this is a study that's already activated and open for accrual. This is SWOG S1827. The acronym is MAVERICK, and that stands for MRI brain surveillance alone versus MRI surveillance and prophylactic cranial irradiation, a randomized phase 3 trial for small cell lung cancer. I'm the PI of this trial, and you can see that we have a great study team here. In the interest of being concise, we kind of don't have the background slides here, but basically the idea of this study is that, as we all know on this call, that PCI has been a very important part of therapy for small cell lung cancer for several decades. And that's recently been challenged by a phase 3 trial in Japan that changed the design by including MRI brain surveillance for all patients. And so in the context of MRI brain surveillance, you can catch brain metastases a little bit earlier, and that may lead to more effective salvage. And sure enough, that study was published in Lancet Oncology in 2017, and there was no difference in survival with PCI. And that was specifically for patients with extensive stage disease. And so that trial has changed the way people feel about PCI. and it represents contradictory data to the EORTC trial that showed a large survival benefit in extensive stage disease. And so that's now a controversial question, the role of PCI in extensive stage. And no similar trials have been done yet for limited stage, and so it's an open question whether MRI surveillance alone might be a good strategy for those patients as well. And so this trial is designed to address the modern role of PCI in both limited and extensive stage small cell lung cancer. And so next slide, please. And so here's the schema. So if we start over on the left, the inclusion is patients with small cell lung cancer, and that includes patients with both limited and extensive stage disease. And I should mention here, there's no, for people who do open this trial, there's no obligation to enroll all of your limited or extensive stage patients. Some people have equipoise for limited, some have equipoise for extensive, and some have equipoise for both. And so if you open this trial, really, we would just encourage you to offer the study to patients, the population for which you have equipoise about. So it's really designed to be open and inviting for accrual. The other inclusion criteria are very standard: no brain metastases, and patients have to have no brain metastases after completion of first-line therapy, just like they would for PCI off trial. And then patients are randomized. It's a very simple randomization to prophylactic cranial irradiation versus not. And all patients undergo brain MRI surveillance, and you can see that schedule below. It's every 3 months during year 1 and every 6 months during year 2. And that follows the Japanese study design for extensive stage. And it's also consistent with the NCCN guidelines, which now recommend MRI brain surveillance for all patients. So there shouldn't be too much pushback in terms of getting those MRIs approved, hopefully. The hypothesis of this study is that in the context of MRI brain surveillance, there will be no survival benefit with the addition of PCI. And it's truly a non-inferiority design that we believe that the survival curves will be very similar. And so that's the primary endpoint is to show non-inferior overall survival with MRI brain surveillance alone. Other standard things there at the bottom, radiation is recommended at the time of brain metastases, and it's designed to be a very pragmatic study design. So we know that whole brain radiation is considered the standard of care for small cell, but there is some interest in SRS and some research that has supported that recently. And that's actually acknowledged in the NCCN guidelines. So if you have a patient that you want to offer SRS to, that's allowed on the trial. Also, it's important to note that hippocampal avoidance techniques are allowed on this study. So hippocampal avoidant PCI and whole brain radiation are allowed. We do track that prospectively to allow for planned subgroup analyses. But again, this is a design that is designed to be pragmatic and inviting. So if that's your standard at your institution, please feel free to think about that for these patients. And the last bullet is that really any and all NCCN acknowledged first-line treatment strategies for limited and extensive stage are eligible for this study. So whatever the first-line therapy that you're offering for your patient, if it's a patient that you would think about offering PCI, then they're a good candidate for this study. Next slide. And so these are just some notes. So this, we have a large accrual goal of 600 analyzable patients for this non-inferiority study design. So we're trying to cast a very wide net, and so it's open across the NCTN, including in the Canadian group. And we are actively promoting this trial in the VA system. We have a dedicated VA study champion, Drew Moganaki, at the Atlanta VA, and Emory University is helping us with that. And again, it's a very pragmatic study design. It's designed to have low barriers to accrual. Of note that the study does have cognitive testing, and I would just note here that the tests, the certification to deliver these tests, as well as our neurocognitive chair, who's Jeff Weffel from MD Anderson, these are all identical actually to very successful NRG trials, NRG CC001 and CC003. So many centers have actually participated in those studies, and it's an identical process. And there are financial incentives for completing these both at baseline and in follow-up. And just again, accrual is really the key here. We've done a lot of polling from different groups, and there are independent patterns of care and studies like that have suggested that this is a really important question to people in the thoracic and radiation oncology community. And so, this is a design that will help us answer this question going forward and can be very helpful to patients, because if patients don't need PCI and they can have equivalent survival without it, then that's important to know, and it can be important for quality of life and a real benefit to our patients. The framing of this question and how we present it to our colleagues and patients is really important. So it's important to note that PCI does remain a Category 1 recommendation for limited stage small cell lung cancer per the NCCN guidelines. And so if we're going to omit PCI, the best place to do that really is on a phase 3 trial like this. And so that gives us the opportunity to do that in a controlled way that helps us answer this question. And then I would just note also that that PCI has been the standard of care for extensive stage for a long time, and it's still considered a standard option for extensive stage, and we have conflicting randomized data. So we don't totally know what the benefit would be on a large trial like this in a North American population. And so this trial is designed to answer that question. Patterns of care analyses suggest that that PCI is still being offered for extensive stage patients at a rate of about 50% in the radiation oncology community. So that's a pretty good indicator of equipoise. So I just ask that you please consider opening this study to help us answer this important question. Really, we need a lot of buy-in from the radiation oncology community if we're going to be successful in accruing and answering this question. And so with that, if there's any questions, I'd be happy to take those, and maybe we could go back to the schema slide just so that could be available.
Yeah, so thanks, Chad. So we're going to have to be quick with questions. I'll just point out that Chad actually presented an entirely different study that he was trying to move forward, and about, I don't know, a month before the meeting said, I really don't want to do that one, but hey, Roy, how about we present this idea for PCI? What do you think about that? And he's done a really tremendous job in moving forward this enormous trial. So we're opening this trial. I hope others are opening it. Just any quick comments on barriers? So someone asked about non-English speakers and neurocognitive testing. I know, Chad, you have an answer to that.
Yeah, absolutely. That's a great question. So similar to other study designs, the ones that I mentioned in the NRG, this study is it's open to non-English speakers, but the cognitive testing only really has validation data in English speakers and French-Canadian speakers. And so the cognitive testing component is only being done in patients where that's their primary language of proficiency. So if a patient is a non-English speaker, they can be offered this trial. They just don't have to do the cognitive testing.
Great. Thanks, Chad. So if anyone else identifies any barriers to this, please let us know. Let Chad know if people have questions. But otherwise, let's support Chad in this. We're going to put some patients on it. We're actually getting this open through our VA as well, and they're pretty excited by it. But we're going to, in the interest of time, move on. So our next speaker is Henry Park. Henry's one of my colleagues here at Yale. He's a SWOG study champion for this NRG trial. So Henry, let's try to be short and sweet.
I'll be super quick here. So just one slide here. Let's see. All right. So yes, LU007, the Raptor study for consolidative radiotherapy versus observation in extensive stage small cell. So following along the same themes of small cell lung cancer. There we go. The benefit of the CREST study, we know of consolidated thoracic radiation in extensive stage lung cancer, small cell lung cancer, was after chemotherapy. But we know now after the Empower 133 study that the new standard of care now is chemo and immunotherapy. So we're not sure yet if this still applies after chemo immunotherapy. So the NRG with this study led by Quinn Lee, I'm sorry, not Quinn Lee, Quentin Nguyen over at MD Anderson. Proposing this study, which is now activated about a month ago. This patient population will be extensive stage small cell lung cancer who've had a stable disease or partial response after 46 cycles of chemo. If they got chemo and atezolizumab, for upfront therapy. And then after that, they are stratifying based on the number of sites getting radiation, whether it's 3 or fewer or more than 3, whether they had a partial response or stable disease, and by their ECOG performance status, which allows up to ECOG of 2. And then what they do is randomize between the standard of care arm on the Empower study, which is to continue immunotherapy as maintenance, versus continuing immunotherapy plus adding radiation up to 5 sites, which is again a little bit different from the CREST study. But the idea that if you have if there's any leftover disease in the chest or even elsewhere, including the liver, adrenal, or other areas, that you can give some dose of radiation to there. The CREST study went up to 30 gray and 10 fractions, but there's a lot of people who go higher doses, about 45 gray in both the lung and the liver. So this allows you to do that either 45 or 30 gray, and then extrathoracic radiation would be 30 gray or 20 gray. So the idea with the phase 2 component is to look at progression-free survival as the primary endpoint, and then the phase 3 being overall survival as a primary endpoint. This again was activated last month, and we'll hope to have it open at our site as well, where and the key is you can treat up to 5 sites if no progression after chemo and immunotherapy. With secondary objectives to be looking at side effects. They're also looking at whether or not you have complete versus incomplete consolidation, meaning that you treated all sites of residual disease or you left some behind. And also if there's a difference between treating 1 to 3 sites versus 4 or more sites.
Thanks, Henry. That was perfect. So this is an important trial. 2 good things to point out. Number 1, we want you to enroll to this trial, and we want you to make sure your institution gives SWOG the credit for it. And just to point out, this is a great role for many of our investigators to become SWOG study champions, and basically get a leadership role in a trial, get authorship on the trial, and really what they ask of you is to, as Henry's doing a great job of, beat the drum for accrual at the thoracic meeting and at the radiation meeting. So again, comments are welcome, and feed them to Henry. In the interest of time, I think we'll move on to our next speaker. So David Horowitz is our GI liaison, and he's going to talk about a trial that's hopefully moving forward in the GI committee.
Very good. Thank you so much, Roy. Can everybody hear me all right?
Yep.
Very good. So this is a study that, pardon me, this is my later slides. Let me go forward a little bit to my next. There we are. Okay. So this is a protocol that has been worked on as an LOI for the Hope Impact Grant, and was selected to go forward for a full proposal looking at patients with locally advanced and high-risk anal squamous cell carcinoma. We all know that, by way of background, concurrent chemoradiation with 5-FU and mitomycin C is the standard of care for anal cancer. And while early-stage disease has good tumor control and disease-free survival, patients with high-risk disease, so tumors greater than 4 centimeters in size or node-positive disease, have very significant rates of failure, up to 70% failure rates at 3 or 4 years on the 9811 and the ACT2 study. And efforts to try to intensify therapy have largely been unsuccessful in terms of neoadjuvant chemotherapy or outback chemotherapy, or even higher doses of radiation boosts given at the end of treatment. This is something that's currently being evaluated on a phase 3 study, the ECOG 2165, which is giving adjuvant nivolumab, which is a phase 3 that is accruing extremely well and should be completing next year. And so we were anticipating the next study might be to try to improve outcomes for this patient population that has significant need. And drawing from some of the exciting results that have been reported for other disease sites, particularly in the head and neck and in the lung arena, chemoimmunotherapy has shown some significant responses. And this was really inspired by a German head and neck study that was reported at ASCO this past year, the CheckRAD CD8 study, which gave neoadjuvant chemoimmunotherapy with a PD-L1 and CTLA-4 inhibitor in combination with doublet chemotherapy. And that, with one cycle of neoadjuvant therapy, actually showed a 50% pathologic complete response rate before going into the definitive radiation component. And so we built this as a pilot, non-comparative randomized study looking at short courses of neoadjuvant chemoimmunotherapy with an IPI and NIVO backbone in terms of the immunotherapy, either combined with cisplatin and 5-FU or carboplatin and paclitaxel as per the INTERACT study, and then leading into standard chemoradiation with dose-painted IMRT as per RTOG 0529 with mitomycin and 5-FU or capecitabine. The primary endpoint is looking at a 3-month clinical complete response rate, which is a short time point, but as a pilot, we felt was appropriate to give us a good signal for efficacy, with secondary endpoints, of course, toxicity. This is a novel approach for this disease site, and so we want to be very mindful of that. And additionally, the gold standard of 6-month clinical complete response, and then 2-year disease-free survival, colostomy-free survival, and overall survival. We felt as though this site also is very amenable to translational endpoints. HPV ctDNA has been shown to be prognostic in the metastatic and in locally advanced settings, but has never been evaluated with response to immunotherapy, and then particularly chemoimmunotherapy. And so looking at HPV ctDNA kinetics was an important biomarker we wanted to look at. And again, this is an accessible site for biopsy. And so we wanted to look at tumor immune microenvironment changes pre and post chemoimmunotherapy to serve as exploratory endpoints for us. This concept's been presented to the GI committee as well as to the task force, and was favorably reviewed, and is the main feedback that we most recently got from the committee was whether this was most suitable as a pilot study, or whether it should expand to a true phase 2 study with a safety lead-in. So I certainly appreciate feedback in that regard. And this is a concept that I'm developing with the mentorship of Dr. Kachnik, as well as Kathy Eng from Vanderbilt and Hagen Kennecke at Virginia Mason, and with another young investigator, Mei Cho, at UC Davis, who's a medical oncologist.
So thanks, David. You got a question on the chat from Charles Thomas asking about the doses of the cisplatin and who is the surgery co-investigator.
So this is an excellent question. So the dose of the cisplatin and 5-FU is drawn from the Dugremont regimen, which Dr. Eng has a lot of experience with, and especially in terms of tolerability. And so this has been published and is her preferred regimen, but is certainly not what we see most commonly. But it's a every other week regimen.
And in fairness to David, I'll answer the second part of Charles' question. Not that we would normally have a surgery co-PI for a chemoradiation trial, but if this does move forward, if our pilot gives a signal, especially if one arm has a better signal than the other arm, Christina Bailey will serve in that capacity, a young surgical investigator. And then one question no one asked, but we've been struggling with, is what about just doublet immunotherapy alone as a third consideration? And Kathy's used it sort of off-label and didn't really see any bang for the buck. So we decided just to go with these two for the pilot.
And so you mentioned you got some feedback that you should do a safety run-in, or so what would that look like? You do the first 10 patients receiving, how would you do that?
Yeah, so we definitely want rigorous stopping criteria, and there are adaptive schema that exists to continually assess toxicity. And so if, depending on the number that are accrued, if we're seeing excessive rates of toxicity greater than, say, 25 or 30% grade 3+ toxicity, that NARM would be halted. And that was really posed in the setting of if this were expanded into just a larger phase 2, which would give more data to inform the next randomized phase 3 study for high-risk disease, that having a very well-defined safety run-in before the full phase 2 would be important.
Yeah, I like the idea of not having a stop to reassess safety, because it's very hard to get reaccrual going.
Okay.
And so, I mean, what this looks like is basically like a phase 2 selection design where
Correct.
you're really just, you got 2 experimental arms, you're looking for a signal with some very loose statistics to figure out which one to move forward with. I think it looks great.
And if the Hope Foundation, the impact award, isn't granted to support a couple centers doing this, the other idea is we could do this through SWOG, just kind of keep it statistically under that 100, so we don't have to go through the NCI steering, and make it sort of a more official phase 2 trial that can then easily move forward to. So but we have those 2 options, but the good news is the GI committee was very, very supportive.
Nice. It's great work. Any other comments?
Oh, David also and May presented it at the task force, and they were also very supportive. So that was good too.
Nice work, David.
All right, thanks very much.
All right, so we have an invited guest at this point. So Barbara Burtness is the head of the Yale Head and Neck Multidisciplinary Program, and actually the PI of our newly funded Head and Neck SPORE. And so she asked for the opportunity to present an ECOG Akron head and neck study. As you guys all know, SWOG does not have a head and neck committee. She's looking for support, and I think saw the opportunity to get 90 radiation oncologists as a captive audience to get some backup on this. So I know Barbara was not initially on the panelist.
Can you hear me though? I think they just activated my audio.
Yep, we can hear you.
Great.
I'll turn it off.
And I think the host was going to be sharing my slides, but so thank you very much, Roy, for the opportunity. And I think we are interested in studying HPV-associated head and neck cancer in the ECOG Akron Head and Neck Committee, and this is something that requires people to work together a little bit because of the fact that it's somewhat less common malignancy. I'm sorry that my slides are not.
Yeah, can we get Dr. Burtness's slides up?
So the trial that I'm talking about is EA3161. It's a phase 2/3 trial for intermediate risk HPV-associated disease. So that's smokers or people with T4 cancer and pre-disease. And we want to ask the question about the incorporation of immunotherapy. And I think people may have seen the Javelin 100 data that came out at, next slide, please. Just move on to the, yeah, so here's the schema. So, you know, there's good evidence that immune checkpoint inhibitors have activity in head and neck cancer. There was good phase 2 data that their incorporation with chemo-RT was safe and seemed to be associated with a high response rate. And a number of large pharma-sponsored studies moved forward that had a design of one dose of immune checkpoint inhibitor, start chemoradiation with an immune checkpoint inhibitor, follow it with a year of maintenance versus standard chemo-RT. And our feeling was that those trials, even if they were positive, and I guess people have probably seen that Javelin 100 was pretty definitively negative in the data that were presented over the weekend, but even if those trials were positive, they might not answer the question for HPV-associated disease, where the event rate's a little bit lower, and where even a slight increase in toxicity could potentially swamp the benefit. And so we wanted to ask the question specifically in high-risk HPV-associated disease, and we wanted to minimize the potential toxicity of incorporating an immune checkpoint inhibitor during chemoradiation. So the way this trial works is people are randomized, but then the first event is the same in both Arm A and Arm B, and that's that they get weekly cisplatin together with radiation. And then once they've finished their definitive therapy, inclusive of a salvage neck dissection, if that's what's required, they then go on to a randomization between a year of nivolumab or observation. And when they progress, they're eligible to cross over to nivolumab monotherapy if that's what they want to do. So we found that this trial is appealing to patients. They like the emphasis on a less toxic way of incorporating immunotherapy, and really welcome your participation. I think the other thing, and I noticed that it's 2 minutes after 12, and I hear the little dings of people logging off, but we would love input from people who have ideas about whether or not the Javelin 100 data should impact the study design. I think the first obvious thing that came out of their forest plot was that the benefit was greater if there was PD-L1 expression, and we may need to revise this to stop accruing people who are PD-L1 negative. But I think the additional question might be, what is the best endpoint? We've used a PFS endpoint in our trial, but perhaps a landmark analysis might be better suited to making the go, no-go decision. So thank you very much for the opportunity to come to you. I'm not going to go through all 17 of my slides because of the time, but if people have suggestions or questions, be happy to entertain those either here or offline.
Experienced head and neck radiation docs on the call. So anyone have any comments about the design, your willingness to put patients on this, competing studies? You like it, you hate it? It's a very quiet group today. So Charles Thomas, will it be powered for certain subsites? So I guess, is there stratification by head and neck subsite, or is the assumption that they're all oropharynx and some oral cavity?
So the assumption is that they are predominantly oropharynx, but I think within oropharynx, there's a lot of discussion about tonsil versus base of tongue versus glossotonsillar sulcus, and are those different prognoses? We are not powered for that analysis. And I will tell you that given that we're enriching for higher stage patients, I think as tumors get bigger, it's harder to say whether it started in the tonsil and grew to the base of the tongue or the other way around. And also, interestingly, in 3311, which was our transoral surgery followed by risk-based postoperative therapy for HPV-positive disease, we did not find the expected survival advantage for tonsil primaries. So it's not powered for that analysis. That is something that we would look at, but I think in this particular patient population with a lot of T4s, maybe might not be that clean to do anyhow.
And so we have another question about radiation dose de-escalation and whether that was considered.
Yeah, so we talked about that a lot, and the feeling was that because we were enrolling specifically people with 10 pack years or more smoking history, or T4 disease or bulky nodal disease, that was a group of patients that still had less than an 80% cure rate, and that it was premature to consider reducing radiation dose. Really, this is an intensification trial because we're adding 12 months of nivolumab, and the goal was to try to find a way to improve outcome without greatly increasing the toxicity of the definitive therapy.
And this with the weekly cisplatin, this is already a fairly non-toxic regimen for such advanced disease.
Yes. So why did we pick 40? You know, we now have the Japan Oncology Group data in the post-op setting showing an advantage for that. There were a number of other 40 per meter squared per week trials going around. The retrospective look from Penn had come out based on the VA data, and we thought that it was becoming increasingly non-feasible to accrue HPV positive trials where you insisted on high dose. So there was a lot of survey work that went into picking this.
All right. Any other specific questions for the group, Barbara?
No, I mean, just if people have specific thoughts about Javelin, we are potentially going to be looking at the eligibility to exclude PD-L1 negative, and you know, are looking for ideas that will increase buy-in. And we hope that you're all thinking about this at your site. As I say, I find it quite easy to accrue to.
Yeah, and I would imagine it would. And again, I have to throw in, and we want you to give, if we can find a way to endorse this, you know, our committee cannot formally endorse an ECOG-ACRIN trial. I think this would have to get endorsed by a disease committee other than ours. And I don't know that there's currently a route for that. Lisa's shaking her head no.
Yeah.
So I would just,
Yeah.
you know, perhaps SWOG would consider allowing you to endorse if there's no disease-specific committee, in which case we would love your endorsement. But
Well, I think we could all separately endorse it through the CTSU at our sites. But my one question was, I'm pretty sure there's an NRG competing trial, at least within their foundation, but I'm not a head and neck person, so I'm not 100% certain.
So there is not a NCTN competing trial. If there is within the foundation mechanism, I can't address, but many institutions would, you know, would be looking to prioritize NCTN.
Yeah, and this
approved trials.
This complements the HN005, I think, right?
Oh, I see. Yes. So the HN005 is exactly this. So you can draw a line, but based on pack year and stage. So patients will either fit HN005 or this. Correct.
Ah, okay.
Okay.
Yeah, exactly right. Yeah.
Good. And Jeremy Kilburn said they're going to open it at their NCORP site. So there you go.
Wonderful. Thank you.
All right. Thanks very much, Barbara.
Thank you for having me.
Yeah, you bet. So we're going to move on to our disease liaison committee reports. We have Reshma Jagsi first. Reshma said, I know she had to run at 12, so I don't know if she's still on or not. She might not be.
Actually, I am. Sorry, I was trying to find my unmute button.
I'll turn it over.
Yep, wonderful. So I'm excited to report on the progress of the breast committee. I'll take the next slide. Or sorry, so I wanted to start with the one open trial that we have going on, which is next slide, SWOG 1706, which is a randomized trial of olaparib administered concurrently with radiotherapy versus standard radiotherapy alone for the treatment of inflammatory breast cancer. Next slide, please. Here's the schema for that trial. As you'll recall, thanks to the wonderful input this committee has provided over the years, the sample size is 300 patients, and we were conservative in our estimate for accrual, 5 patients per month for 5 years, given how rare inflammatory breast cancer is. Really exciting news that even despite COVID, we've actually hit and on one occasion surpassed the 5 patients per month in the past few months. And so we're up to 54 patients as of August 28th. The first amendment adding quality of life and some clarifications has been approved by the CIRB, and all seems to be going well with that. I will take the next slide. We have one important trial that is in development led by Eileen Connolly. Next slide, please. This is a phase 2 study seeking to evaluate recurrence following IORT for DCIS after breast conserving surgery. You can see here that the primary outcome is local failure, specifically locally recurrent disease in the lumpectomy bed, calculated from the day of lumpectomy to 5 years, as well as a number of important secondary outcomes and translational medicine outcomes that you can see listed here, which I won't actually verbally say for you because I think you can read them more quickly than I can read them to you. Although I'm going to try by talking fast to read them faster. Next slide, please. Here is the money slide, as you said. The schema is always the money slide. So here's the money slide for the schema for the trial. And as you can see, all of the enrolled patients receive lumpectomy and IORT, specifically 20 graded lumpectomy bed delivered using low energy X-rays with various systems. And the postoperative pathology determines the risk stratification with adjuvant whole breast radiotherapy being recommended but not required for the high-risk patients at a dose of 40 gray and 15 fractions. Next slide, please. So this has actually been approved by Triage. Eileen has been amazing at securing industry support and pushing this steadily through the process. The translational medicine proposal and statistical plan have been reviewed and approved. The financial plan is nearly complete, and she's working actively with IROC about RT credentialing, which actually is a remarkable feat for her, given that there are currently no national standards for IORT. So kudos to Eileen for doing really yeoman's work here for the field and to investigate a very important subject for us. Next slide. We also have one actively championed trial in another group. That is, next slide, the NCIC MA39 trial. It's Taylor RT, and it's specifically looking at patients with N1 disease who are essentially randomized to receiving regional nodal radiotherapy or not. So if they've had a lumpectomy, all of them get whole breast irradiation, and the randomization is regional fields or not. If they've had a mastectomy, then the randomization is radiation or not. And next slide. Oh, sorry. I didn't stick another slide in there. Sorry. I could just say what I was going to say. I have more slides for the breast committee. They are actively loosening the criteria for that trial, given some analyses that have been done of the NSABP B28 data that suggest that perhaps more patients might be candidates for omitting regional nodal radiotherapy and allowing it to accrue faster. Accrual's actually not been terribly bad. It hasn't been quite what they had hoped, but it has picked up since the last time, and we have been relatively marginal contributors within SWOG, specifically in that, unfortunately, many of us are at institutions where the radiation oncologist will enroll a radiotherapy trial patient via NRG, and so these get counted as NRG accruals, but nevertheless, SWOG has been integral in introducing this trial early to patients, because I do believe my colleagues in the breast committee, most of whom are medical oncologists, have been identifying patients, referring them for this trial. And so we are important partners in championing that. And then, sorry, next slide. Finally, we have one championed trial in development in another group. And next slide, that one is NRG BR007, which is the DEBRA trial looking at de-escalation and specifically omission of breast radiotherapy after breast conserving treatment for stage 1 ER positive, HER2 negative, low oncotype DX recurrence score breast cancer. And Dean Shumway is going to be our study champion for that. We just received the protocol consensus review back, and the study team just met yesterday with CTEP to discuss that. All of the comments, although there's 53 of them, seem remediable, and so I guess it's better to get a lot of comments that you can address than a few comments that you can't. So the study team is actively working on that, and you can see the schema there as well. So that's what's going on in the breast committee. Lots of cool stuff. I think that's about all I have. Sorry, tried to keep it under my 3 minutes. I don't know if I succeeded.
Reshma, that was fantastic, and you really kudos for some great trials you've helped push through the breast committee, including some real radiation questions. So yeah, you've done amazing work there. Any comments, questions for Reshma? Any barriers to enrolling on these trials? I know we've got some of them open. All right. We will move on to GI. I think Dr. Yu is on the phone, or I could walk down the hallway and knock on his office.
And it's GU.
What did I say, GI?
Yeah, wrong title.
Well, you know, I try to stay above the diaphragm, as you know.
So, GU, yeah, and I'm presenting on behalf of Jing Zhang and the GU committee. Next slide. This is going to be super fast. So I'm only going to highlight 2 studies. There's a million GU studies, renal, bladder, and prostate, but this one in particular is relevant to radiotherapy. It's the randomized phase 3 trial of standard systemic therapy plus or minus definitive local treatment, SWOG 1802. Next slide. And so it's a 2-step registration. Step 1, you register the patient, you decide on the best systemic therapy, and then you randomize between local therapy or not. Next slide. That local therapy can be surgery or radiation. The surgery arm is actually accruing very well, not arm, but surgery stratum is accruing very well. And we actually need more radiation patients. I know since the onset of Stampede H, a lot of us are already doing local therapy for metastatic disease. So this is a difficult randomization, I think, for many of us. But please do consider if your institution does have equipoise in this question. It feels like there's equipoise in this question to enroll radiotherapy patients. Next slide. Again, we need radiation patients, otherwise this is going to be a surgery study. And if you do enroll a radiation patient, make sure you're not just getting the dregs of patients who are not surgical candidates. Otherwise, the radiation stratum is going to be underperforming, and I can see that used against radiotherapy in the future. So again, patients need to be operable candidates who just decided to get radiation, not inoperable candidates that are getting radiation. So SWOG 1802, please consider opening and enrolling at your center. Next slide. And contact Brian Chapin or S1802 question@SWOG if you have any questions. Next slide. Okay, this is the second trial that I'm going to highlight, and this has been open for a while now. It's SWOG 1806, phase 3 trial of concurrent chemoradiation with or without atezolizumab for a muscle-invasive bladder cancer. It's a SWOG NRG intergroup trial spearheaded by SWOG and NRG. Next slide. Now, once again, muscle-invasive bladder cancer, randomized to chemoradiation with or without atezolizumab. So very important question. We know atezolizumab does have activity for bladder cancer. It's a very nice study for those of us who believe in chemoradiation for bladder cancer, which I think is everybody on this committee, but not necessarily the urology members of SWOG. So certainly an important study to accrue to. Next slide. Primary endpoint is bladder intact, event-free survival, data randomization, the first documentation of a bladder intact event. Next slide. Secondary endpoints include metastasis-free survival, progression-free survival, and a biopsy second look at about 18 weeks. Next slide, please. Oh, that's it. I'm done.
Thanks, James. Yeah, it's really embarrassing to lose out to the urologists on that 1802. So we should definitely work to get some patients in there. Yeah, as everyone knows, we're always fighting for relevance in prostate cancer. Any questions for James? Any comments about the GU portfolio? Otherwise, we'll move on to lymphoma. I don't know if Dr. Constein is on. I did not check.
Yeah, I'm here. Can you hear me?
Yes, we can.
Yeah, I'll be super brief. We just have the one study, which is quite an excellent study. So I hope you all get a chance to participate. Next slide. So this is the randomized study of nivolumab and AVD or brentuximab and AVD for newly diagnosed advanced stage classic Hodgkin lymphoma. And what's remarkable about this is it's a combined study with the Children's Oncology group as well as SWOG. So it will be quite a large study for classic Hodgkin lymphoma, perhaps the largest intergroup study which will have been done. Next slide. So I'll just show you the schema. Next slide. Yeah, here's the schema, newly diagnosed stage 3 and stage 4 disease. You can see that it's on nivolumab and AVD versus AVD, 6 cycles. There'll be an end of therapy assessment. And I won't go through the nuances in the interest of time. We can go to the next slide. So radiation will be delivered to patients who are Dovil 4 or Dovil 5 at completion of therapy. They must have had at least 50% reduction in the maximum transverse diameter to be eligible. If they haven't had that much reduction, then it's considered refractory if they are also Dovil 4 or 5. The lymph node itself must be more than 2.5 centimeters, and or it could be an extranodal site that's more than 1 centimeter. There can only be 1 or 2 sites of disease, not more than 2. Now, the centers must declare their intention to use radiation at registration, and in the SWOG group and the other adult groups. But in COG, all the patients are going to get radiation. It was expected that because the adult groups have been adverse to radiation for advanced stage disease, that few patients would be declared for being for that intention to use radiation. But it turns out that about 75% of the patients so far registered have been registered with the intention to use radiation. So I think that's good for us, at least, because we've been trying to demonstrate that we can give radiation safely. And I think most of us would agree that somebody who was Dovil 4 or 5 after 6 cycles of aggressive therapy should be somebody that radiation would be appropriate for. So I'm delighted, actually, that the centers who are enrolling patients have declared that 75% of those patients should be eligible for radiation. It turns out only about 10% will ultimately receive radiation. And we had our COG meetings last week and heard from IROC, and no patients have actually had radiation and had their data submitted. So I didn't put all the radiation information on the slide, but essentially the dose is 30 gray with a 6 gray boost. And so the concept is to treat the and it's only to residual disease. So what you would do would be to focus your radiation field on what's anatomically abnormal, and that would get 30 gray, and then you would boost the area of petability to 36 gray. So the way the protocol is written is that it's a boost following the initial 30 gray. Although I think we're going to put an amendment in, I hope, that will make it possible to use a simultaneous integrated boost. And you could choose, for example, 1.5 to 30 while treating 1.8 to 36. But the concept is to treat area of residual Deauville avid disease for patients who have responded. Now, if a patient becomes Deauville 3, for example, and then is Deauville 5, then that's considered progressive disease, and that patient is not eligible. I think there was another slide. So, yeah, so this shows you that this is actually an old slide. We had an update, and I think there are about 175 patients who have now been
I just lost audio. I don't know if anybody else did.
I did too.
Okay.
Next slide.
Oh, there we go.
That's it. So I hope you all, this has to do with the impact of COVID. There have been some changes in terms of the flow of data and seeing patients. Any questions?
Questions or comments? Anyone? Okay. Thank you very much. I appreciate all these great reports, and it's nice to see all this, radiation-specific research being done. I think our next is Evan with the Melanoma Committee.
Can you all hear me?
Yes.
Okay, good. Thanks for the opportunity to give a little update on the events around the SWOG Melanoma Committee. Next slide. There are 3 currently active studies in the SWOG Melanoma Committee, none of which particularly have directly to do with radiation therapy. There's a pembrolizumab study in patients with locally advanced metastatic desmoplastic melanoma that's been going for a while. Desmoplastic melanoma is a small subset of other of melanoma in general. Then there's also a TVEC and pembrolizumab study in patients with advanced melanoma that have progressed on either Nivo or pembrolizumab. And then there's also a study of adjuvant, large adjuvant study is neoadjuvant pembrolizumab versus adjuvant pembrolizumab in patients with stage 3 or resected stage 4 melanoma. Next slide, please. I also wanted to make sure that everybody was aware of, because many of us are involved in several cooperative groups, the main another main study that's going on in the cutaneous oncology space is this ECOG study, forget what the number is, 16 something, but it's a Merkel cell carcinoma study for patients with stage 1 through 3B Merkel cell carcinoma, in which patients are randomized to pembrolizumab or observation after radiation therapy if you choose to do postoperative radiation in those patients. And so this study has been struggling a little bit. That's why I wanted to make sure I included it, so that if you take care of, or whoever in your at your center takes care of Merkel cell carcinoma, please alert them to the fact that this study is out there and available. It has very broad inclusion criteria, so many patients are eligible. It's a good way to, it's an important study, because we know that anti-PD-1 therapy benefits patients with metastatic Merkel cell carcinoma. So the next obvious question is, will it benefit patients with stage 3 resected Merkel cell carcinoma? Next slide. The major radiation oncology related plan as it pertains to the melanoma group is to do a secondary analysis of SWOG 1404. So 1404 was SWOG's giant phase 3 randomized trial comparing basically it's old school immunotherapy versus new immunotherapy. So because this sort of overlapped a interval in time at which interferon and then ipilimumab became available. So patients on one arm could have either of those two, or pembrolizumab in patients with high risk resected melanoma, so stage 3 melanomas. The study was activated in 2015 and closed about 22 months later, and in 2 months had accrued 1,378 patients across all of the U.S. sites. The interesting thing about this study is that adjuvant radiation therapy in this study was left up to the physician team's discretion. So some patients had adjuvant radiation, some high-risk patients with bulky nodal disease had postoperative radiation, and some were from centers that didn't really believe in it and so didn't have postoperative radiation therapy in addition to their clinical trial therapy. So we're planning to analyze the regional progression-free survival, overall progression-free survival, and overall survival in high-risk patients and compare between those groups, those patients that received adjuvant radiation therapy and those that did not. And there's also a potential for a combined analysis with another ECOG large adjuvant study that looked at adjuvant ipilimumab versus adjuvant interferon that was just published earlier this year. Next slide. So this secondary analysis could try to address the question or the hypothesis of even in the era of more effective immunotherapy, patients at high risk for regional nodal recurrence may benefit from adjuvant radiation therapy. And we do have some data. This is a table that was published in the New England Journal of Medicine around the time that some of the EORTC adjuvant trials came out, which gave an idea for some of the local regional recurrence rates among patients being treated with adjuvant immunotherapy types. And what I sort of take from this, if you look at the local regional recurrence only areas of these studies, there's still, and this is just in an unselected population, so this isn't even the high-risk population, this is just all stage 3 patients. There's still a pretty decent percentage of patients, despite modern immunotherapies, that seem to be having local regional recurrences only. And obviously, we'd like to try to figure out who that group is, and if that group is the same as the group that was studied in the SWOG study, which can put adjuvant radiation therapy and melanoma kind of on the map as a possibility, and try to refine those criteria and pick out the patients that are most likely to benefit. Because those patients that are most likely to benefit are the ones that are going to have a local regional recurrence, a regional recurrence only, and not those that are destined to go on to have a widespread recurrence everywhere. So that's what we're kind of planning for a secondary analysis of this large trial. I think that's all the slides I have, so I'll take any questions that anybody has. And thanks for the opportunity to present.
Thanks, Evan. That secondary analysis is fantastic. That just should be really interesting. It's a great opportunity, and nice job kind of jumping in there. If there are no other comments, we'll move on to myeloma. Chelsea, I think, is on the call.
Sorry, I'm unmuting and I'm in clinic, so this will be quick. I'll take off my mask here. Hi, everybody. Next slide. So the major challenge that we're facing in the myeloma committee is, one, there's very little use of radiation in a definitive management for these patients, with the exception of solitary plasmacytoma. And the Alliance trial was launched several years ago and closed prematurely after accruing only 11 patients, which was designed to ask in my opinion, what is probably the most relevant question right now on this patient population of solitary bone plasmacytoma patients, which is there benefit to the use of adjuvant systemic therapy after completion of definitive radiation? Just showing this was the initial trial design. And ultimately, in trying to investigate, next slide, what was the source of poor accrual, it seems pretty much multifactorial. A lot of the champions, I think, might have, regarding radiation, were brought in kind of late into the game. And this was a study that was pioneered by Anuj Mahindra, who's at Scripps. And so some of the radiation champions, Muhammad Khan was involved, but in speaking with him, involved a bit late in the process. A lot of these patients, I think, might have seen radiation oncologists for their treatment of the plasmacytoma, but then were never referred to medical oncologists. And the way the trial is designed, the randomization happens after completion of radiation. Another potential barrier that I think was that there was 2 bone marrow biopsies. So we need a baseline bone marrow biopsy to establish diagnosis, and that would happen before radiation. But then when patients were registered and randomized after completion of radiation, there was a requirement for another bone marrow biopsy. And I think that might have also been a deterrent from participation from some patients. That's just my sense. Next slide. Regardless, though, I think this question still has merit, and we've been discussing in the myeloma committee over the past year or so different approaches to ask this question again. There's retrospective data that have small series that have been published that's suggesting that addition of systemic therapy leads to decreased rates of progression to multiple myeloma, and that's the key pattern of failure in these patients. You know, more than 50% of them will go on to develop multiple myeloma. Next slide. So this study is actually open and accruing in the UK. They're using adjuvant Revlimid and dexamethasone after completion of definitive radiation therapy for high-risk plasmacytoma patients, which would be considered solitary bone. And so there is one study that's ongoing, clearly, but not in the US. Next slide. And so in these patients, there have been several biologic agents that have been used concurrently for patients that receive treatment for multiple myeloma. And so we're not proposing that treatment would occur concurrently with definitive radiation for the plasmacytoma patients, but this is just going to show that there is lots of data to support the fact that the agents that are often used in this setting are safe. Next slide. And so the initial thought was to use Revlimid and dexamethasone because that's an active regimen in patients with smoldering myeloma, which are patients that basically have a very low burden of monoclonal plasma cells in the marrow, but not high enough to justify full-blown myeloma therapy. But given that that study is ongoing in the UK, it's the same regimen they use, we didn't think it makes sense to do the same thing. For patients that have untreated multiple myeloma, daratumumab, lenalidomide, and dex have been shown to be active regimen. And so most recently in our last committee, we kind of settled on this approach as our adjuvant regimen. Next slide. And so the trial design right now is still a bit in its infancy. This is just showing kind of the scheme of the treatment in terms of the drugs. It's basically 28-day cycles and 6 months of therapy that patients would receive if they're randomized to the adjuvant chemotherapy arm. Next slide. And so, you know, the primary endpoint would basically be progression to multiple myeloma at 3 years. It's basically a PFS endpoint that would include progression to multiple myeloma or development of a new plasmacytoma outside of the radiation field. Lots of secondary endpoints, and we would like to involve very early on radiation oncologists. And I think that could be the key and the difference in this trial being successful as opposed to having the unfortunate fate of the previous study. I have been cautioned that the NCI is probably going to be, there's not going to be a lot of enthusiasm about putting a lot of money again and time into this approach, but into this study. But in my opinion, like, this is the only really relevant question in this patient population. It's a relatively rare tumor, so it has to be done in a cooperative group. So I am invested in putting in the time and energy to see if we can get this trial launched again. And I would, if anyone that's on the call that had potentially enrolled someone in the Alliance study or considered it, I would love to have your feedback as to why, any challenges that you faced or any reasons why patients weren't enrolled. You can email me, or if someone has any suggestions now, that'd be great. And that's a typo, not allowing randomization before and after completion of RT, but allowing registration. I think the randomization would still occur after completion of radiation therapy. That's it.
So thanks a lot, Chelsea. I'm going to make one comment on that. One of the strategies that did well for us in the thoracic committee was sending out surveys. And so when we got feedback from the NCI that there would not be enthusiasm, we were able to present some data that said, look, we've got all this buy-in. And but I think the difficulty, you're already aware of the difficulty, right? You're going to want to capture all those, radiation oncologists that are maybe associated with some of our community sites that may not be on all of the, emails and communications from SWOG. So
Right.
You got some challenges, but it's a good study. It's a good question.
Okay. Thank you.
Okay, so I left myself for last, so let's move on to the thoracic committee. So there we go. So I only have 2 slides here, are kind of active and proposed studies, and then some of the champion studies to go over. So we have 3 active radiation studies in the thoracic committee right now. We have the S1914. This is Megan Daly's study. It's a randomized phase 3 trial of SBRT with or without atezolizumab in stage 1 non-small cell. There are a number of competing trials for these stage 1 patients with immune therapy. I honestly feel like this one has the best design. The atezolizumab is given up front. It's only given for 6 months. And this does allow the enrollment of patients who elect against surgery. So this is a trial that should be easy to enroll to. We're starting to activate it at our institution, hopefully very soon. And Megan asked me to make a pitch for people to open enroll to this. It's actually a nice, a relatively small population compared to the Pacific study that's going on and the Merck study that's going on. So I think this will enroll quickly if we can get it open and going. So I would really recommend this highly. It's a great study. There's no placebo. It should be a really easy sell to patients. If anyone is aware of any barriers or has any questions, let me know, reach out to me or reach out to Megan, please. Chad already mentioned the SWOG 1827. Surveillance imaging versus prophylactic cranial radiation. This is going through the activation process at many institutions now. Again, I think this is a really critical question. This may be our last opportunity to answer it, and I think this would be a fantastic trial to be able to complete. The 1933. So Rod Ajamali is the PI of this, and Tim Mitten is the RT chair. So this is a phase 2 feasibility study of hypofractionated radiation, which is 60 gray and 15 fractions, followed by atezolizumab consolidation in patients with stage 2 or stage 3 non-small cell who have borderline performance status. So essentially patients who are not eligible for chemotherapy have the opportunity to get a short course of radiation followed by immune therapy. This is has a accrual goal in the, I think it's approximately 60 patients, so I've lost track. But again, I think this is a great study. This patients at our institution have been asking about access to immune therapy drugs when they're not able to get chemotherapy. So I think this should be good. I would encourage you all to open and accrue to it. We have another trial that's been approved by committee and is currently being discussed back and forth at the NCI. This is the S1934. So this is a trial in superior sulcus tumors. I think we actually changed the acronym. I think it's now got a different acronym, not TrustIO. I think it's ASSIST. But essentially, this adds chemoradiation plus immune therapy preoperatively before for resectable and marginally unresectable superior sulcus tumors. Ray O is the PI of this. I serve as the RT chair. We hope to activate this soon. SWOG has a great successful history of establishing the standard of care in superior sulcus tumors, and that's the goal here, is to continue that. So we have the buy-in of the other cooperative groups on this. We're excited to get this open. Hopefully, get it through and get it approved. There are a couple of proposed studies. So Arya is unfortunately withdrawing his SBRT study. He didn't have a chance to take this out of here. There is a randomized phase 2 study of durvalumab in patients with residual disease after trimodality therapy for N2 stage 3A. This is a study that's been back and forth to committee a number of times. It is essentially the Pacific study in patients getting preoperative chemoradiation followed by surgery who have residual disease. It's a smaller population to draw from, but it's a nice design, very simple. And hopefully that will make it through committee. At some point, there have been some delays. So next slide. So we have a number of other group studies open which have SWOG study champions. So Charles is the study champion for the LU-005, which is chemoradiation versus chemoradiation plus atezo in limited stage small cell. We've got one SWOG accrual so far. So again, I would encourage you all to accrue to this, which will help our investigators get authorship credit here. I accidentally put the ALK master protocol on here. I have no idea why. I must not have had enough coffee that day. The LU-02, Dan Gomez is the SWOG champion for this. This is, again, kind of a landmark, potentially landmark study of consolidation SBRT for oligometastatic non-small cell versus maintenance therapy. This is a trial that accrued slowly at first, but is gaining momentum. So this is going to be a successful study. We've not done a great job of accruing, at least with SWOG credits yet. So I would encourage you all to do that. Lori Gaspar is the champion for the CC03. And Henry Park already presented the Raptor study, the LU-07, did a nice job. I'll recommend that one highly. That's a great question. Our own medical oncologists here at Yale do not like to give consolidation radiation when they're giving atezo for extensive stage small cell because it was not included in the trial that established that. So this is a great way to convince them all that we're still relevant in small cell lung cancer. So that's what we've got going on in the lung committee so far. If there are any questions about that, they'll take them. I have to say, when we drew up the agenda, I really had no hope at all that we would actually reach the Q&A before 1 o'clock, but we have. So we have about 10 or 15 minutes. If people have any other questions or issues that they want to raise, now is the time.
Roy, if I may interrupt, I'm sorry, this is David. I think that the GI slides were placed earlier in the deck.
We didn't even do your GI report. I apologize,
Correct.
Dave. Yeah, so let's do that.
I apologize.
No, I'm glad you brought it up.
Okay, so this is the oh, this is not the start of the deck. I apologize. Could we see the next slide? Next. No. No. One more. Not.
Wrong direction.
I think that these were.
How we're going to.
Yeah, if we could go back.
Design.
Oh, perfect.
There we go.
So there are several studies that the GI committee is championing, put together by other cooperative groups, which are important at our various sites. So just very briefly going from stem to stern, Dr. Lin is the PI on the NRG GI 006, which is an important phase 3 trial looking at proton beam versus IMRT for treatment of esophageal cancer, either in the definitive or neoadjuvant setting, and is building on the data that he's presented and published at ASTRO. Next slide, please. This trial is accruing pretty well, with over 10% of patients accrued so far, and with co-primary endpoints of overall survival and grade 3+ cardiopulmonary toxicity, in addition to all of these secondary endpoints that are described. Next slide, please. So this is a newly opened trial, the ECOG 2183, which I think is important. Similar to what's been described earlier by Dr. Amini, looking at a phase 3 trial looking at consolidative radiotherapy in patients with oligometastatic esophagogastric cancer that are HER2 negative. And so these are patients with metastatic disease at presentation, and this is a first-line trial for patients with 3 or fewer metastatic sites. Patients are initially randomized to FOLFOX or CAPOX, and then undergo a second randomization at a 2-to-1 ratio to receive consolidative ablative radiation to the metastatic sites versus continued chemotherapy. This trial opened just prior to COVID, and so has not accrued very many patients so far, but I would certainly encourage everybody to consider opening this trial. Next slide. And again, this is powered for an overall survival endpoint, and because of COVID, has accrued only 6 so far. So there's a lot of work to be done on this. Next slide. There are 2 hepatocellular carcinoma trials which do somewhat compete with each other. The RTOG 1112 has been ongoing for several years now, and is unfortunately having difficulty because of a change in the standard of care in terms of systemic therapy, now with atezolizumab and bevacizumab preferred in the US over upfront sorafenib. But again, this is Dr. Dawson's protocol looking at daily sorafenib versus SBRT followed by sorafenib, and includes patients who have vascular involvement. Next slide, please. And again, this is powered for overall survival. However, due to difficulty in accruing, they have revised their accrual goal down from 368 to 292 subjects. And again, we anticipate that probably Canada will be the main area where these patients continue to be accrued. Next slide, please. The other hepatocellular carcinoma study is looking at protons versus photons for HCC. And again, you can give either SBRT in 5 fractions or hypofractionated 15 fraction regimen. Next slide, please. And this is Dr. Hong's study with, again, an overall survival endpoint. So this is an important radiation question to answer for this disease site. And this has accrued 50 patients. Almost a third of the patients have been accrued so far. Next slide, please. Getting farther down, so as I spoke of earlier, the high-risk anal cancer trial looking at adjuvant nivolumab is accruing extremely well, and this was expanded from a phase 2 to a phase 3 study looking at adjuvant nivo for 6 cycles versus observation for patients who have high-risk anal cancer. Next slide. And as this went to a phase 3 design, they significantly expanded the number of subjects to be accrued, but they anticipate closing this trial in the next year. Next slide. And then on the opposite end of the spectrum for anal cancer, there's the decrease study. We know that our standard per 0529 has been to give 50.4 gray in 28 fractions to the primary tumor, and then 42 gray to the elective nodal regions with mitomycin and 5-FU. But for these small lesions, there's data that suggests that there is good local control with lower doses. Remembering back to the NIGRO regimen, initially just 30 gray was given. And so this is a phase 2 trial looking at de-intensified chemoradiation with lower doses of radiation and single cycles of mitomycin and 5-FU or Xeloda. Next slide, please. This is a very interesting study looking at both disease-free survival and quality of life. And we know also from the IMRT study of looking at anal cancer that many patients required plan revisions before they could be approved for treatment. And so one of the secondary endpoints is to determine the utility of e-contour to improve target delineation in anal cancer. So I think that there are a lot of important questions to be answered with this study. I think that those are all of the radiation trials that we're championing right now in the GI committee. And then additionally, the protocols in development are the anal cancer pilot and then the secondary analysis that we're doing for gallbladder and extrahepatic cholangiocarcinoma. Thank you.
Thank you very much, David. And I apologize for giving you short shrift and leaving you as tail end Charlie there.
Oh, that's all right.
So I appreciate it. So one question from Charles Thomas, any pancreatic studies in the queue? Anything being discussed?
So there are several studies that are being discussed. Most of them are not radiation related, to be honest. And so this is actually on our pancreas subcommittee meetings is an area of particular interest. So if there are people who have proposals to put forward, I think that this is something that could be of interest, both in the locally advanced or even medically unresectable space. People have expressed interest in developing a trial, and we certainly are always advocating in the adjuvant setting that radiation is not just excluded out of hand for patients who have R1 resections. And I think that we're gaining some traction there, but that it's certainly an area of challenge for us.
Thanks. Sounds like a potential opportunity. So I want to, I guess, wrap up by saying thanks to everybody for making the time today, for the great comments and questions. Again, if you notice any of your colleagues that should have been on the list that were not, please let me know. Otherwise, if you need to reach out to Lisa or I, we're available as much as we can be. Thanks very much, and hopefully we will all see each other in person in the spring. So Lisa, any final words, or are we good to go?
I think we're good. Thank you so much. I think this has been a great meeting, despite the change from live to virtual. Thank you, Roy.
Thanks, Lisa. All right, everybody, I'll give you back 3 minutes, so enjoy your day.